All right, let's dive into a topic that's incredibly high yield for clinicians and often pops up on exams: hyperkalemia. It's a critical electrolyte imbalance.
Ooh, hyperkalemia. That always sounds like something really serious. What exactly defines it?
You're right, it is serious. We're talking about a serum potassium level typically exceeding 5.0 to 5.5 milliequivalents per liter. It's truly a medical emergency due to its profound effects on the heart and muscles.
Wow, that's serious. So, beyond just that number, what does hyperkalemia actually look like in a patient? The symptoms can be pretty varied, can't they?
They really can be nonspecific, which makes early recognition challenging. The most common things we see are generalized muscle weakness and fatigue. Patients might also report paresthesias like tingling or numbness and palpitations.
Muscle weakness, fatigue, and palpitations. Okay, so those are some key red flags. How might an MCCQE1 question present the scenario?
Great question. Picture this. A 68-year-old male comes into the emergency department. He's complaining of muscle weakness and fatigue that's gotten progressively worse over the past 24 hours, and he's also having intermittent palpitations.
Okay, 68, muscle weakness, palpitations. What's his medical history?
He has type 2 diabetes mellitus, chronic kidney disease, stage 3 specifically, and hypertension, and for those, he's taking lisinopril, hydrochlorothiazide, and metformin.
Ah, chronic kidney disease and lisinopril, that's quite the combination. So in this specific case, considering his symptoms and medical history, what is the most likely diagnosis?
Given that complete picture, particularly the CKD and lisinopril use, which can both elevate potassium, his presentation strongly suggests hyperkalemia as the most likely diagnosis. It's a classic setup.
Makes sense. All those pieces of the puzzle really point towards that critical electrolyte imbalance. It highlights how important medical history and medication lists are.
Absolutely. Recognizing these risk factors and symptoms together is paramount because prompt diagnosis and management are crucial to prevent some really life-threatening cardiac complications.
So the urgency is absolutely there. We need to unmask this hyperkalemia challenge quickly to prevent things from escalating. I get it.
So we've talked about the symptoms and the urgency, but let's dive into one of the most crucial initial investigations, the electrocardiogram, or ECG. It really is a window into the heart's electrical activity, especially when potassium levels are out of whack.
Right. I remember it being highlighted as providing vital information for treatment urgency. So what exactly are we looking for on an ECG when we suspect hyperkalemia?
Excellent question. The ECG changes are a critical aspect of interpretation lab/imaging for the MCCQE1, and they directly correlate with how severe the potassium elevation is. This is key for determining the next best step in management.
Okay, so it's not just a yes or no, but a spectrum of changes.
Exactly. Let's start with mild hyperkalemia, typically when potassium is between 5.5 and 6.5 MEq per liter. The hallmark here is tall, peaked T waves.
Oh, like those narrow, symmetric, almost tented T waves, often most obvious in the precordial leads?
You got it. They're usually the first warning sign. It's subtle but significant because it tells you the heart is starting to feel the effects, even if the patient isn't overtly symptomatic.
Wow, that's serious. So essentially, the ECG is already telling us there's an issue even at mild levels.
Precisely. Now, if potassium continues to climb into the moderate range, say 6.5 to 8.0 milliequivalents per liter, things progress. You'll start to see prolongation of the PR interval, the P wave might flatten or even disappear, and crucially, the QRS complex will start to widen.
So the electrical impulses are slowing down and the ventricles are taking longer to depolarize. That sounds pretty concerning.
It absolutely is. It indicates increasing cardiac toxicity, and if we don't intervene, things can get really bad. Severe hyperkalemia over 8.0 milliequivalents per liter is truly life-threatening.
What happens then? A sine wave pattern was mentioned in the source material, which sounds pretty dramatic.
It is dramatic and terrifying. The QRS widening continues, and it might actually merge with the T wave, creating this continuous undulating waveform that looks like a sine wave. This pattern directly precedes ventricular fibrillation or asystole, which of course means cardiac arrest.
No way! So from peaked T waves to a sine wave, the heart is essentially telling you it's shutting down. That's an incredibly important interpretation lab/imaging point for the exam and for real life.
It truly is. Understanding this progression on the ECG is critical because it dictates the urgency and aggressiveness of your emergent management.
Right, because if you see those severe changes, you know you're dealing with a rapidly escalating emergency.
Absolutely. The ECG is not just diagnostic, it's a direct guide to how fast you need to act to prevent a cardiac catastrophe.
It makes so much sense how crucial it is to get that ECG immediately for anybody suspected of hyperkalemia.
Definitely, it's the first real-time indicator of the heart's distress, showcasing the dire progression of cardiac changes that can turn fatal.
Given that urgency, you absolutely need two things right away: immediate serum electrolytes and an ECG. Those are your absolute priorities. The ECG we just covered, but the serum electrolytes confirm the level and much more.
Right, so it's not just about confirming the high potassium, but also seeing the bigger picture. Why else are those immediate serum electrolytes so crucial?
Exactly. You're simultaneously checking other electrolytes like sodium, chloride, bicarbonate, calcium, magnesium, and phosphorus. This helps identify any underlying causes or coexisting imbalances that might be contributing or need correction.
Makes sense. So essentially a comprehensive metabolic panel to cover all bases?
Precisely. And with that panel, you're assessing crucial things like renal function through BUN and creatinine. Our patient had CKD stage 3, so kidney function is a huge red flag here.
Wow, that's serious. And glucose is part of that too, right?
Yep, glucose is important to assess for diabetes and also because it directly guides whether you'll need to use insulin glucose therapy as a management step later on.
Okay, so electrolytes, renal function, glucose. What else should be on that initial investigation list, especially if we're thinking about those shifts in potassium we discussed earlier?
A blood gas analysis. That's key for identifying acidosis. If a patient is metabolically acidotic, that can actually cause potassium to shift out of the cells and into the bloodstream, making the hyperkalemia worse.
Right, so correcting the acidosis becomes another way to help manage the potassium. What about a complete blood count?
A CBC is definitely important. It helps us rule out pseudo-hyperkalemia from hemolysis.
Pseudo-hyperkalemia? What's that?
Sometimes, if a blood sample is drawn incorrectly or mishandled, the red blood cells can rupture in vitro, releasing their intracellular potassium and giving a falsely high reading. It's not true hyperkalemia, but it sure looks like it on the lab report.
No way. So you could be treating something that isn't actually there if you don't consider that? That's a high-yield point for sure.
Exactly. These initial investigations aren't just about confirming hyperkalemia, but really understanding the full clinical picture: what's causing it, what other imbalances are at play, and what steps to take next.
It really feels like detective work, getting all these clues from the tests to pinpoint the problem and guide the next steps in management.
Absolutely. And getting these pieces of information quickly informs our next critical phase: emergent management.
So, absolutely, getting this information quickly informs our next critical phase, emergent management. And when we talk about emergent management, we have to start with stabilizing the myocardium, which is essentially cardiac protection.
Right, that's the first thing you go for, especially with those ECG changes we just discussed. What's the go-to agent for that?
The absolute first priority for symptomatic or severe hyperkalemia with those worrying ECG changes is cardiac protection, and for that, we turn to calcium gluconate 10% or calcium chloride 10%.
Okay, so calcium. But I remember reading something really interesting about calcium's role here. It doesn't actually lower the serum potassium levels, does it?
Exactly. That's the kicker and a crucial point for the MCCEQE1. What's the mechanism of action for calcium in this scenario if it's not actually reducing the potassium in the blood?
So essentially, it directly antagonizes the cardiac membrane effects of potassium. It stabilizes myocardial excitability, protecting the heart, but doesn't remove potassium from the body. Wow, that's serious.
That's spot on. Calcium acts like a shield for the heart. It prevents the deadly arrhythmias, which is the most acute, life-threatening complication, without actually changing the potassium concentration in the blood.
That's incredible, given the rapid onset of cardiac issues with high potassium. How quickly does this protection kick in?
It's incredibly rapid. The onset is typically within 1 to 3 minutes, which is why it's the immediate intervention. You can see those ECG changes improve almost instantly.
That's fast, so it buys you crucial time. But what about its duration? Is it a long-term fix?
No way, it's not. The duration is quite short, only about 30 to 60 minutes. So while it's life-saving, it's definitely not the end of treatment. It's a bridge to other therapies.
Makes sense. So to ensure continued cardiac protection, what would be the next best step in emergent management if the ECG changes persist after the initial dose of calcium?
You can repeat the dose of 10 milliliters of 10% calcium gluconate in another 5 to 10 minutes if those ECG changes haven't resolved. It's all about rapid response and closely monitoring the patient's cardiac status.
And between gluconate and chloride, is there a preference?
Calcium chloride actually contains 3 times more elemental calcium than gluconate, making it a stronger option. It's often preferred in critical situations, especially if central access is available, due to a higher risk of extravasation with peripheral use.
So it's potent but needs careful administration. It seems the main takeaway here is that while calcium is a critical immediate intervention for cardiac protection, its effect is rapid but temporary.
Exactly. It's a very short window where we've stabilized the heart, but we haven't actually addressed the root cause or the elevated potassium levels themselves. It just buys us time. Exactly. It buys us precious time, but doesn't actually remove the excess potassium from the body. So what is the next best step in management to truly address and reduce those dangerous potassium levels?
That's the crucial pivot. After cardiac protection, we're looking at ways to actually shift potassium away from the bloodstream or remove it entirely. The first approach is shifting it intracellularly, right?
Precisely. We use agents that temporarily move potassium from the extracellular space into cells. A prime example at a high-yield MCCQE1 topic involves insulin and glucose.
Okay, so insulin stimulates the Na plus K plus ATPase pump, which actively drives potassium into the cells. And the glucose is co-administered to prevent the patient from becoming hypoglycemic, which would just create another problem.
You've got it. It's effective with an onset of 10 to 30 minutes, though its effect lasts only 4 to 6 hours. We also have beta-2 agonists, like nebulized salbutamol, which also stimulate the Na plus K plus ATPase pump, specifically in skeletal muscle.
Wow, that's serious. So essentially, both are temporarily tucking the potassium away until a more permanent solution can be found. What about sodium bicarbonate? I've heard that mentioned.
Sodium bicarbonate is primarily effective in patients with metabolic acidosis. By correcting the acidosis, it causes potassium to shift back into cells. Its direct effect on potassium shifting in non-acidotic patients is actually minimal, so it's not a go-to for everyone.
Makes sense. So those are the shifting mechanisms, but as you mentioned, that's not actual removal. What are the methods for truly getting potassium out of the body?
Great question. What is the most appropriate agent to increase renal potassium excretion in a patient with intact renal function? Could be an MCCQE1 question. The answer there would be loop diuretics like furosemide.
Because they increase the kidney's ability to excrete potassium. But that's the catch. They require intact renal function, which many hyperkalemia patients, especially those with CKD, might not have.
Exactly, which highlights why considering the patient's underlying conditions is so vital. When renal function isn't sufficient, or if we need to remove potassium from the GI tract, we turn to potassium binders.
Right, like sodium polystyrene sulfonate or Kxalate, which exchanges potassium for other ions in the gut. But isn't there a black box warning for Kxalate?
There is for intestinal necrosis, especially when combined with sorbitol. Newer binders like patiromer and sodium zirconium cyclosilicate, or Lokelma, have a better safety profile and are becoming more common.
That's good to know. And then, for the most rapid and effective removal, especially in severe cases or renal failure, it's hemodialysis, correct?
Absolutely. Hemodialysis offers immediate and continuous potassium removal, making it the fastest and most definitive treatment when other therapies aren't enough or aren't working fast enough. So we've got the temporary shift, and then the more permanent removal strategies using diuretics, binders, and dialysis depending on the patient and urgency.
It really covers all the bases, from quick fixes to definitive solutions. It's about buying time, then shifting, and finally removing the potassium to get levels back to normal.
Precisely. Understanding this multi-pronged approach is key. We first protect the heart, then buy time by shifting, and ultimately eliminate the potassium from the body with these various methods.
That overview of shifting and removal strategies is incredibly helpful. Now, to truly prevent recurrence and understand the patient's full picture, we need to dive into the root causes and risk factors for hyperkalemia, which often drive the need for all these interventions.
Indeed, knowing the why behind the high potassium is crucial for long-term management and prevention.
So, what are the common culprits we need to be aware of when thinking about risk factors/etiology for hyperkalemia?
Let's unpack that. It often boils down to issues with the kidneys, medications, or even certain medical conditions that cause shifts in potassium. Renal failure is, of course, a huge one.
That makes total sense given the kidney's role in excretion.
Right, and then there are a whole host of medications that can contribute, Exactly, and that leads us right into exploring why hyperkalemia occurs, because it's not always just one simple thing. Did you know that some common medications, even for high blood pressure, could dangerously spike potassium levels?
Wow, that's serious. So, beyond what we've already covered with the acute management, what are the primary root causes we should really be thinking about?
Well, the most common culprit, hands down, is decreased renal potassium excretion. Our kidneys are typically fantastic at getting rid of potassium, but if they're not working well, like in kidney failure, potassium can build up.
Makes sense. So, if the kidneys are failing, that's a huge red flag.
Precisely, but as you just alluded to, medications are massive contributors. Things like ACE inhibitors and ARBs, which are commonly used for hypertension and heart failure, can impair aldosterone production, reducing potassium excretion.
Right. I remember lisinopril was mentioned in our case vignette. So what else should we watch out for?
Potassium-sparing diuretics like spironolactone, amiloride, or triamterene are direct offenders. And surprisingly, even NSAIDs like ibuprofen can reduce renal blood flow, leading to issues.
No way. Even something as common as ibuprofen? That's really eye-opening.
Yep, and here's another one. Trimethoprim, often found in combination with sulfamethoxazole, acts similarly to a potassium-sparing diuretic in the kidneys. Beta blockers can also impair cellular potassium uptake.
That's a lot of common drugs that could be problematic. Are there other non-medication causes beyond kidney issues?
Absolutely. Metabolic acidosis, for instance, often seen in diabetic ketoacidosis, causes potassium to shift out of cells into the bloodstream. Think of it as hydrogen ions moving in and potassium moving out.
Ah, so it's a trade-off. What about things like trauma or other types of injury?
Good question. Cell lysis from conditions like rhabdomyolysis, tumor lysis syndrome after chemotherapy, or even significant burns can release a flood of intracellular potassium. Adrenal insufficiency, like in Addison's disease, is another cause due to decreased aldosterone.
So it's either the body can't get rid of it or something's making too much of it available in the blood. Given all these causes, who's most at risk for this whole situation?
That's a crucial point for prevention. Patients with chronic kidney disease, especially stages 3 to 5, are highly susceptible. Those with heart failure are also at high risk, often due to the medications they're on.
And I imagine our diabetic patients would be a concern too.
Definitely. Diabetes mellitus can lead to hyporeninemic hypoaldosteronism, and it's a major risk factor for CKD. Older patients are also more vulnerable, often dealing with polypharmacy and multiple comorbidities. It really boils down to knowing who to watch closely.
So it's really about knowing the patient's full medical picture and what medications they're taking to anticipate this.
Exactly, because prevention is always better than emergency management. Understanding these risk factors is vital for proactive care.
It highlights how critical it is for clinicians to review that entire medication list.
Absolutely, and that's what we'll dive into next, the overall takeaways for the MCCQE1, connecting all these critical dots.